طيب مساء الخير جميعا. كونجراتيوليشن دكتور صبحي في كل سنه يعني الهايبرتنشن هايلايتس اللي احنا دايما بنستمتع بيها. Let me welcome the panel, Professor Jamila, Dr. Hussam, Dr. Ahmed Hawari. We have a session now about hypertension and the comorbidity. We have 3 presentations, and because of sake of time, let me introduce the first presentation, hypertension and the kidney. I think a lot of questions tonight about this issue. Dr. Josep Redon from Spain will give this presentation. Dr. Josep.
Okay, and good afternoon again. We will follow with my voice for 15 minutes. The second talk of today, for me, it's a new insights of renal disease and hypertension. And I allow it to put this first slide always. Then this is one slide, one renal biopsy, the same patients. This is the left kidney, and this is the right kidney. And then you will see that there's a patient with diabetes, and then you will see a Kimmels-Wilson clear, and then you have some alteration of, but not as much like this. What is the differences in between these 2 biopsies? The difference is that this kidney is protected with renal artery stenosis. In other words, the blood pressure in this kidney is lower than the blood pressure in the other kidney. Then this is a very, very nice and morphological evidence about the impact of blood pressure at the time to produce renal damage. And renal damage that is not only produced by hypertension. Renal damage, there is a combination of several things in which, of course, hypertension is very important. The overactivity of the renal-angiotensin system, if the patient has hyperglycemia, if the patient develops proteinuria, and then when proteinuria itself is damaging, but also salt intake, dyslipidemia. In other words, not forget about age. Then this is the complex scenario in which hypertension, elevation of blood pressure, is impacting in the kidney. Then in the following minutes, I go to review mechanisms, some clinical issues that I think that are relevant, how to protect the kidney, treating that's not only hypertension. And finally, I will finish with next steps and conclusions. According to the mechanisms, it's, well, from the beginning was in the study of hypertension was accepted that the renal damage will come from ischemia due to the elevation of blood pressure and the time that the blood pressure was elevated. And this is, the impact of ischemia is true in atheromatosis vascular disease or malignant hypertension. And then this ischemia produces glomerular sclerosis, but there is another mechanism, is the presence of low preglomerular tone. This low preglomerular tone that produce glomerular hypertension, glomerular sclerosis, and finally arrive to a reduced number of nephrons. But the low preglomerular tone is not only impacting the glomerular site, it is also impacting the pericapillary tubules and the interstitium. And then here, in the pericapillary tubules in the interstitium, produce ischemia in the medulla, produce an increment of the sodium reabsorption, and also that lesions and ischemia in the tubules and interstitiums. And this low preglomerular tone is more frequent in diabetes, is more frequent in obese, is more frequent in African American, in elderly subjects, and it is more frequent at night. But not only this, recently, one of the mechanisms that impact the interstitium of the kidney is the transition due to this hypertension in the pericapillary tubules produce an endothelial mesenchymal transition of cells that impact and produce fibrosis. Then this is what we can see concerning blood pressure itself. But we need also to consider the frequently hyperglycemia is present in patients with hypertension. This hyperglycemia leads to hyperfiltration and overactivity of the renal angiotensin system because the increment of reabsorption of sodium with the co-transporter that arrives sodium to the area of where mechanisms of tubulo-glomerular feedback is produced, producing an increment in the filtration fraction. This filtration fraction increment is producing damage in the glomerulus. But not only this is important, these mechanisms, there is another mechanism important damage in the tubule, that is that the increment of tubular oxygen consumption at the time that needed for more reabsorption of glucose and sodium. This lead to the expression of cellular stress markers, NGAL, KIM1, and progressively tubule hypertrophy and elongation that is increased the workload contributed to the kidney hypertrophy. Then we have mechanisms that are impacting the glomerulus, mechanisms that impact the tubules, and mechanisms that impacting the interstitium of the kidney. And another important mechanism that today is linked in the renal damage is the interaction in between the tubule and the glomerulus, the podocytes. The tubule have a secretion not in normal conditions of one molecule that's sirtuin. The sirtuin is a molecule that increasing clouding, it maintains the structure of the podocytes in good shape and then in good function. When this damage in the tubule is produced, there is a decrease in the sirtuin secretion, and then produce and prolong the lesions that can be produced for other mechanisms, but also this is an important one, and it is clearly related, the levels of sirtuin with the damage in the glomerulus. Then we have mechanisms, some ones that are very well known, some ones that today are being used for treatment, but there are another that in the future need to be into account. What about some aspects of the clinical issues? Well, it's clear that the impact of the kidney can produce or can contribute to the nephrangioschlerosis, can lead to reduction of glomerular filtration rate or increase of the urinary albumin excretion, that increasing the risk for end-stage renal disease. But also, another more important, because we are at risk of this, is the occurrence of acute kidney injury. And then it's clear that we know that the presence of urinary albumin excretion increases the level of proteinuria or microalbuminuria, and a reduction in the glomerular filtration rate, of course, is a risk factor that increases the risk of the patient with hypertension and the same level of blood pressure. The presence of one of these, one reduction in glomerular filtration rate, or one increment in microalbuminuria or in proteinuria, is indicating more risk, but more risk for cardiovascular disease. Of course, that if you have proteinuria, you have a reduced glomerular filtration rate, you have more risk to progress the lesion of the kidney. But also, it's a very, very good marker for the increment of risk of cardiovascular risk. Then, there is another aspect I need to consider. At the time that to develop renal damage, albuminuria is not necessary one step to develop chronic kidney disease. Then you will see here how, of course, if you have a patient with albuminuria with the same levels of glomerular filtration rate, you have more risk to develop chronic kidney disease. But the risk to develop can exist also without the presence of albuminuria. And in this case, even if you have the glomerular filtration rate lower than 90, of course, the presence of microalbuminuria or proteinuria increases largely the risk, but not always. You have also a 20% of subjects that in the follow-up develop chronic kidney disease. In other words, we need to consider both together urinary lumen excretion and glomerular filtration rate. But if you don't have urinary lumen excretion increased, you are not sure that the patient is not going to reduce progressively the glomerular filtration rate and have chronic kidney disease. But what is the most important? The most important is how to protect. We can diagnose very easy, but how to protect this? To protect this, we need to combine several things. You need to combine treatment for hypertension, but you need to take in account that you are going to protect to reduce cardiovascular and renal events, but you need to be careful in hypotension, derived symptoms, and derived events of hypotension. Because if you have derived symptoms of hypotension, or more, if you have events, the adherence to treatment, quality of life, and survival can be modified. Of course, you need to take in account also dyslipidemia, even that is not maybe the most important one. But of course, also you need to consider what is happening in the glucose metabolism. And then you also need to consider what are the kind of drugs that you are going to use, because also, according to the drugs that you are going to use and the goals that you establish for the glycated hemoglobin, you will have also changes in adherence, quality of life, and survival. Move first to the glucose-lowering drugs. Just only one slide. This is a few slides I'm going to present. The first, this is a summary of the majority of the glucose-lowering drugs, oral ones, in terms of reduction renal risk, reduction cardiovascular risk, no increment of cardiovascular risk, and increment of specific risk. And if we are talking about the kidney, then you will see that today it is considered that the inhibitors of the co-transporter glucose sodium are those that are achieving the best results in the treatment. The best results, even that initially they have a reduction in glomerular filtration rate. But in long term, this initial reduction stabilizes the changes over time, and this is data from the EMPOREC study, but also has been that reproduced in other glyphosines that are in the market. But then what is interesting to see is that initially that have a reduction in the glomerular filtration rate. But after, this reduction is maintained at the levels because they are protecting to decrease. Because in these mechanisms to reduce is because reduce the filtration fraction. Then, what about, that this is more relevant for us today, is the antihypertensive treatment. The antihypertensive treatment, then I show initially this slide from data from the own target that has been recently published in one paper that also Professor Mansia and myself, we are here. And then you will see how, according to the blood pressure achieved during the treatment, in these patients that have high-risk patients, that the risk to develop new microalbuminuria is largely reduced. The lowest the blood pressure, the lowest the new microalbuminuria. But at the same time, you will see here what happened. The lowest the blood pressure achieved in diabetic patients and in non-diabetics, the increment more than 40% in the glomerular filtration rate or end-stage renal disease increases. Then we have here the paradox, and not as much paradox, but also we have the doubt. What will be our actions at the time to protect the kidney? Which are the levels that we need to use, that we need to achieve in order to achieve the better protection. Then you will see here one meta-analysis of subjects in which there has been compared subjects that receive a regular blood pressure lowering treatment or those that have intensive blood pressure lowering. Intensive in terms to reduce blood pressure close to 130. And you will see in these subjects with non-chronic kidney disease, you see that there are no differences in the composite renal outcome and no differences in all-cause mortality. However, if you move a subjects with chronic kidney disease stage 3 and 4, there is a trend to reduction, the risk, when you are using intensive blood pressure control. Then we have here some controversial information. But what have also in our scenarios? In our scenarios is what I say you before, that is the risk for acute kidney injury. These are data from the SPRINT trial. And then you will see this is the risk to develop acute kidney injury in subjects in the intensive arm of the treatment. In other words, intensive treatment in these patients increases the risk of acute kidney injury, that this is a factor of risk to develop end-stage renal disease. What about other information about large trials, follow-up in large periods of time? This is the AKKS study, in which there are subjects, the cumulative incidence about standard control or intensive control. Then you will see that in the double-blind period, there are just a few differences in both, but the differences in intensive or standard control appears over time. And then this intensive control, for sure, this increment of the survival in the cumulative incidence of event is present in subjects with proteinuria. In subjects without proteinuria, there were no differences initially or during the follow-up. Another of the classic studies that also has published the follow-up long-term later is the MDRD study. The MDRD study, during the double-blind period, there were no differences in between achieving one target below 140/90 or perceiving below 130/85. But in long term, then this was differences. The only few differences that appears here was also with subjects with proteinuria. In other words, what can be done? What is the most solid information in order to protect the kidney? Then this is why the guidelines, as you will see here, that is the only group in which the target was not recommended to go below 130, if not to maintaining 140 to 130 if tolerated. But here, the guidelines say one important thing. The important thing is that in these patients, what we are trying to protect the kidney, you need to individualize treatment. And the individualized treatment should be considered according to its tolerability and impact in renal function and electrolytes. Then, what about next steps? And I will back to the goals. The next step is what will be the prognostic value of 24 hours ambulatory blood pressure. All of you know that there are alterations in circadian variability in the patients with chronic kidney disease, and then there is a less decline of blood pressure at night. And then you will see in this trial in which those subjects that have control, office and ambulatory, ambulatory, the risk is the lower, in order to develop end-stage renal disease or death or even cardiovascular events. You don't have control in office or ambulatory, then the risk is the higher. But of course, those that are controlling ambulatory, even that not in the office, the risk is more close to those that have both control. Then we published years ago one study from a center in which in patients with CKD stage 3-4, the risk to end-stage renal disease or doubling serum creatinine was clearly related with the 9-time blood pressure. Well, with all of this in mind, what is the recommendations that I think that will be considered in that? Overall, you need to achieve less than 130/80 or even lower if no side effects, and I'm going to speak about monitored creatinine and potassium. In subjects with proteinuria, the goals should be lower because that has been in those that have more risk and then the beneficial impact exists. But if you have patients with some degree of fragility, to maintain around in between below 140/90, it's okay. And also, it is interesting to have and to see control during 24-hour nocturnal blood pressure. But what about the monitoring of creatinine and potassium? Go to when you start antihypertensive treatment in one patient with that you need to protect the kidney. First, you have an initial acute fall, and the patients are receiving in the treatment blockade of the renal angiotensin system. If there are less than 20% of reduction of glomerular filtration rate, you follow treatment. If you have more than 30%, exclude that renal artery stenosis and reduce those or even withdraw the treatment. If you have a reduction in between 20 and 30, you reduce dose and check and adjust the diuretic dose if present. This is produced because you have two things. You are modifying the glomerular tubular balance and you are reducing blood pressure. But if you have the same fall in no blockade of renal angiotensin system, then you have, if you is only less than 20%, follow treatment. But in these conditions, more or less, you need to reduce dose and check after, because here you are producing reduction in the mean blood pressure. And then the reduction in glomerular filtration rate is induced by this reduction in renal perfusion. Then, to take home messages, I think hypertension largely increases cardiovascular and renal risk. And new knowledge in mechanisms can increase potential intervention to protect the kidney. But a renal risk reduction requires integrated approach. Intervention and goals should be tailored in order to reduce side effects and improve compliance. And of course, combination therapies for both blood pressure and glucose control on top of lifestyle changes is key to get success. And back to my previous concept. In these cases, you need to individualize, and you need to monitor what is happening with the glomerular filtration rate and with the levels of potassium. Thank you very much for your attention.
Thank you very much, Professor Redon. Beyond the numbers of the systolic and diastolic blood pressure and what we see now for the individualized treatment and the reduction of the eGFR and how to manage, which tools I should use? For example, if I use calcium channel blockers, which one?
Well, that's, to protect the kidney, it is accepted that the first is a drug that blocks the renal angiotensin system. This is no question. But usually, the patients with renal damage, that they needed combination therapy from the beginning. And in the combination therapy, of course, you can choose for calcium channel blockers or diuretic. Of course, I didn't mention that if you have a patient with a reduction of glomerular filtration rate below 45 milliliters per minute, of course, maybe you need to use diuretics of loop. But I prefer, if there are not edema, I prefer to start with a combination, blockade renin-angiotensin system and calcium channel blocker.
Okay,
And for the calcium channel blockers, do you prefer amlodipine or verapamil?
No, of course, one dihydropyridine. No question.
okay. Any question from the audience about the hypertension and the kidney? Okay, if there is no further questions, so thank you, Dr. Redon, and we'll move to the next presentation.
Thank you very much.